Okay, thank you.
Thank you so much.
Next, we have Dr. SHIKHA, Suresh, and who will be talking on assessment of change in foveal avascular zone area in POAG and PACG patients after glaucoma surgery.
Good morning. My topic is on assessment of change in foveal avascular zone area in POAG and PACG patients after glaucoma surgery. Foveal avascular zone is the round capillary-free zone within the macula. It is usually delineated by fundus fluorescent angiography, which is an invasive procedure. Nowadays, OCT angiography, which is a non-invasive procedure, is used for assessing foveal avascular zone. It allows depth-selective visualization of retinal and choroidal vascular networks by detecting the endoluminal blood flow. There is limited exploration of FAZ behavior in different types of glaucoma, specifically PACG. So, investigating how FAZ area changes differ between POAG and PACG patient can provide insight into the pathophysiology and responses to surgical intervention. Aim and objectives are to assess changes in foveal avascular zone area in POAG and PACG patients following glaucoma surgery using OCT angiography and to correlate changes in the foveal avascular zone area with changes in the IOP in POAG and PACG patients. Study site was Glaucoma Department Combe Trust. Study population POAG and PACG patients undergoing glaucoma surgery. It was a prospective observational study. All patients, POAG and PACG patients undergoing IOP lowering surgery, either TRAB or phacotrabeculectomy was included in the study. Eyes with significant ocular pathologies that bias FAZ area was excluded. History of ocular trauma, uveitis, Parkinson's disease, Alzheimer's disease, stroke, trabeculectomy with complications and poor quality scans were excluded. All patients underwent a detailed history. Anterior and posterior segment evaluation was done, IOP gonioscopy was done, HFA and OCT RNF was taken, and they underwent OCT angiography. OCT angiography was used to assess foveal avascular zone area preoperatively as well as 3 months postoperatively. In both superficial as well as deep plexus, 2 examiners manually measured the foveal contours and the average of the 2 readings was taken. IOP and FAZ area was measured 3 months postoperatively. Total sample size was 41, which included 23 POAG and 18 PACG patients. Preoperative and postoperative IOP in POAG and PACG patients and change in IOP. We can see in both POAG and PACG patients, there was a reduction in IOP with a change in IOP statistically significant in both the groups. In FAZ area in superficial vascular plexus preoperatively and postoperatively, there was a reduction in FAZ area in the superficial vascular plexus, but the change in FAZ area in POAG group was statistically significant when compared to PACG groups. When it comes to deep vascular plexus, FAZ area was reduced with both change in FAZ area in POAG and PACG group statistically significant. Correlation between change in FAZ area in superficial vascular plexus and change in IOP. In both the groups, there was a weak negative correlation, but it was not statistically significant. When it comes to deep vascular plexus, in PACG groups, there was a negative correlation which was statistically significant. So, our study found out that FAZ area was decreased in both superficial and deep vascular plexus after glaucoma surgery in both PACG as well as POAG patients, and the changes in IOP and FAZ area in deep vascular plexus in PACG patients showed significant negative correlation. According to our study, deep vascular plexus showed a more significant reduction when compared to superficial vascular plexus. This suggests that the deep vascular plexus is more sensitive to IOP lowering procedure. Also, it highlights the potential of FAZ deep vascular plexus as an indicator, prognostic indicator of microvascular improvement after glaucoma surgery. Also, this underscores the importance of analyzing both the superficial as well as deep vascular plexus separately in future studies. According to Takoi Shoji et al., FAZ area in superficial vascular plexus was significantly decreased, and they proposed that it was due to enhancement of the perifoveal microvasculature with restoration of the macular retinal ganglion cell function after IOP lowering. According to H.Y. Park et al., there was a decrease in FSH area in the deep vascular plexus. Thun Chang et al. Study was slightly different from our study, where they found out that there was an increase in the FSH area at 1 month, which reverted back to normal. They have said that this increase may be due to surgical inflammation, and the surgical inflammation can result in poor quality scans, and our study has excluded poor quality scans. So our study concluded that foveal avascular zone area in both superficial vascular plexus and deep vascular plexus was decreased after combined cataract and trabecular surgery in both PACG and POAG patients, and the significant reduction in IOP and the associated changes in FSH area suggest that glaucoma surgery may improve retinal perfusion. So what this study adds to literature is that it strengthens the understanding of how lowering IOP with trabeculectomy affects retinal vascular health, and employing a non-invasive modality like OCTA for predicting prognosis following glaucoma surgery. Unlike previous studies, this study highlighted the differential vascular response in superficial and deep vascular plexus, which is relatively a novel aspect in glaucoma research. The limitations are duration of follow-up should have been longer with larger sample size. Measurement of FSH area may be influenced by combined cataract surgery, and measurement of FSH area was done manually by tracing FSH contours, which may cause errors. So future studies with larger sample size and longer duration of follow-up is recommended to analyze the clinical implications as well as to explore the utility of OCTA. These are my references. Thank you.
What was the pressure difference? I didn't get it actually. Pre-op and post-op, how many millimeters average?
So this was,
yeah.
So there was a decrease of 7 mmHg. 7 mm. 7 both the groups. So
it's your study. This was done at 3 months time. Another yes, study 1 month. That's a transient increase you showed.
Yes, sir.
No? So whether that reflects anywhere in the field or any other functional quality?
No, sir.
No. Whether it's analyzed?
No, sir. It was not analyzed.
Not analyzed. So suppose whether this can happen in medical control also?
Sir,
medicine. Say if you start treating a patient without surgery, suppose a patient having 30 IOP, you medically control it, whether this can happen?
Sir, actually IOP lowering can cause, it can increase the ocular perfusion pressure, but I haven't tested for that, sir.
And another aspect I want to see that how many of these patients had a prostaglandin treated?
Sir, actually most of the patients were treated with prostaglandin analogs only previously.
No separate separation in this study, no?
No, sir.
Okay, thank you.
Good, ma.
Thank you,
I think there are many arms for this particular study, you know. For example, the duration of duration of glaucoma we don't know. So that is number one. Okay. Number two, reduction in FAZ. Your fields, your foveal threshold will also change. That will be also a good parameter to study, when you extend the study.
Okay, sir.
Isn't it?
Yes, sir.
When FAZ is becoming better, your foveal threshold in your 24-2 or 30-2. So that will give more value for this also.
Okay, sir.
But overall, you are taking only surgery for POAG, PACG. As sir was asking, so, do you categorize them pre-op and post-op?
Yes, sir.
And the variation in pressure change also will vary. Does that have an effect? So you need to correlate, reducing up to 8 to 10 millimeters or reducing to 2-3 millimeters. Again, so multiple correlations you do, you will get better outcomes. Continue doing this. All the best.
Okay, sir.
So, how will you decide on this trabeculectomy or phacotrabeculectomy? In which all patients you do trab or trab alone and phacotrab?
Sir, ma'am, if cataract is not dense, we do trab alone.
And for phacotrab patients, is it? Can you get this
actually
pre-op OCTA?
We have excluded poor quality scans.
Okay. Then how will you decide this POAG and NTG? Have you ruled out NTG?
Yes, sir. Yes, ma'am.
Okay. Then another is PACG surgery, they were on also medical management or directly anti-closure
No, ma'am. All were on
chronic
medical
patients.
management.
All PACG were also chronic patients
Yes,
or
chronic patients only.
chronic CACG patients, not following an acute attack.
No, ma'am.
No vascular compromised
No,
like
ma'am.
that.
Thank you.